exciting. So our next speaker, I am very honoured to introduce this afternoon. Lena Chowdhury-Salter, founder and CEO of Mosaic Community Trust, who has very kindly joined us after just returning from a long-haul flight, so we are most grateful. Thank you very much, Lena. Lena has 30 plus years of experience leading global health and community programmes, including reproductive health initiatives with international organisations. Her work for many years in the UK has been focusing on empowering socially disadvantaged women, influencing healthcare, service delivery and policy, and reducing health inequalities. Mosaic, her organisation, takes a community assets-based approach together with an impactful network of community advocates. I personally have had the privilege of working closely with Lena and the Mosaic Community Trust here in London over the past few years in my role with the North Thames Genomic Medicine Service, together with Imperial College London, working on several research projects and more recently collaborating on a successful series of grassroots workshops, integrating genomics and research participation and, importantly, health literacy. So we are very happy to have Lena with us, and please give her a warm welcome. Thank you.
Thank you very much. Thank you all for inviting me. And Tina, thank you so much for that amazing, kind and generous introduction. And I would also like to say a bit about Tina's involvement. Tina played a real instrumental role in introducing maternal genomics to Mosaic. We had no idea Genomics England existed until one day Tina told us, there is this opportunity for you to get involved and get some funding support and spread the information, education about maternal genomics. So we educated ourselves first before we could disseminate the information with our community. So a huge thanks to Tina, and also through Tina, we were able to mobilize some amazing specialists. I don't know what to call them. They're so amazing. They're just not ordinary professors or consultants or specialists. They are like Kat is one of us, one of our collaborators. And there's several like Claire, Chauvelin, and many, many wonderful, beautiful people we managed to collaborate with from Imperial, who played a huge role, in fact, transformational role in bringing about maternal genomics and maternal health into the socially deprived grassroots communities. I'm a bit jet lagged, as Tina said, so please forgive me if I'm mixing up my words. So it's all lack of sleep and long haul. I come from India in the south of the country, so it was a very, very long flight and many delays. So please forgive me if I'm just a bit not so clear. So first of all, I'd like to remind ourselves about the definition that we use with regard to preconception precision health. I'm sure the whole of this morning and afternoon you must have been talking about it, but I still, for my own benefit, like to take you through this definition that we have adopted. Preconception precision health refers to the comprehensive approach to health that women and couples undertake before conception to ensure a healthy pregnancy and delivery. The goal is to identify and manage any health issues that would affect the pregnancy and delivery. PPH is not a one-size-fits-all approach. It is highly personalized and considers the unique health profiles and needs of both partners. So with this definition in mind, what we have done, we have kind of divided this into three parts. So this is the three-part framework which we use to delivering health literacy. And the first one is comprehensive health approach. And when we talk about comprehensive health approach, it's not just physical, but physical, mental, social well-being during pregnancy or before pregnancy. And we have to say, even before marriage, because we're only talking about during pregnancy or preconception, but most of our issues that I'll take you through can be prevented if only they had adequate knowledge, information about who they should marry or not marry. And right now, this has become a kind of political issue. And even our government in this country is refusing to talk about these issues before marriage. There's no education at all. They're just about introducing some kind of interventions after they become pregnant about close relations marriage. And especially among Muslim communities that we work with, this is such a common practice. And there are so many huge negative outcomes. And we are all aware of it. We don't want to talk about it because it's not politically correct. So I want to focus on that, how important it is, health literacy, to deliver this comprehensive health approach. We work in Church Street area. Kath and Tina are very familiar with this area. It is the most socially deprived area in the whole of Westminster, maybe even by national standards. This is a community predominantly from South Asia, the Bangladeshis, Arabic community from Middle Eastern, like Syria, Iraq, Kurdistan, and then you have huge North African population. And then there are other smaller groups like Chinese and Southeast Asia and a small East European and so on. But majority of them, in fact, all the people who use our services live in council accommodation. And this is not any council accommodation. Church Street Council accommodation is known for poor, housing, full of condensation, full of fungus, overcrowding, very bad in disrepair. Then they are all illiterate. There's very, very high level of illiteracy. Maybe sort of very few of them have some low education, and they're all unemployed on social benefits, housing benefits. And they're ridden with traditional kind of misinformation, disinformation, misconceptions, and their usual sources of information are their neighbors or relatives from the countries of their origin. So they are the trusted advisors for, go-to for everything and anything, especially health-related. And we also know from Westminster Council's own public health statistics, these people live at least 25 years less. The lifespan is less than the neighboring boroughs and neighboring wards like Maida Vale or St. John's Wood, Marylebone, and so on. This Church Street is just walking distance to St. Mary's. We are just close neighbors of St. Mary's. And this, in spite of that relationship, in spite of the fact that almost all the mothers have delivered their children in St. Mary's, there's still, if you look at Mosaic's insights, many participants report never being informed about misconception care. When Faye was making, I just joined Faye's presentation right at the tail end. So, and that's when she said 80%, I think, or they do consult and have had some form of GP consultation prior to the pregnancy. I'm not very clear, but something like that hit me. And that's when my blood pressure went up. Because none of them, that we work with a population of about 10,000 people. And if you look at all the mothers who come to our groups, large numbers over 20 years of our history in Church Street, not one person has mentioned having any form of preconception consultation, meeting, or information from anybody, except from their, neighbors and relatives, mainly from mother-in-laws, who are the worst people to give any information. And so this is the background. Health education is limited, when it comes to early engagement awareness, it's non-existent. So this is the kind of situation we are dealing with. So the second part of the definition is identifying and managing risks. This is very good because I'm following soon after Faye. She also mentioned about risk factors and so on. But this, again, there's so many opportunities like Faye mentioned, but these are not accessed for so many reasons, mainly cultural, social reasons, barriers. And Faye was talking about family history, taking family history. How many people do you think in our community that we work with would be happy to share their family history with a GP? Not one. There is absolutely no trust between our communities and the GPs. No trust between communities and NHS providers. There's no relationship. They go to midwives when they become pregnant and they take families. They don't give any relevant information to them for so many reasons. They hide, some of them hide any information that may make them feel ashamed, embarrassed. There's a lot of fear. And they even think about things like, oh, they may report this to the Home Office or social services. It may affect our immigration status, or it may affect our becoming, raising a family here. All sorts of misinformation and disinformation, which gives them the fear, suspicion of sharing information. And in most cases, they don't even know about family history. They come from such remote rural areas. They've never heard about having this family history of any long-term conditions, inherited conditions have any relevance to their pregnancy or childbirth. So I can go on and on and on talking about just this aspect, the cultural, social barriers which prevent our global majority communities from having this open, honest conversations with any of the health providers, especially GP practices. And Faye said that it's important for mothers to have this preconception consultation with the GPs. I don't know which GP service she belongs to, but I'm sorry, Faye. When we pick up the phone in Church Street, any of the 8 practices, first thing is the receptionist. Unhelpful receptionist who is the gatekeeper. Is it medical emergency or clinical emergency? If it is medical emergency, go to the A&E. If it's clinical, go at A&E. So now we've told them, don't ever say it is medical or clinical. So we have to educate our women not to use these words. So they have to say certain things. If they say, we want to have a preconception conversation, that's definitely, you'll have to wait for 3 years. No, I wouldn't be surprised. Even when there's some urgent primary care issues, they don't get an appointment. The Church Street is a sort of typical inner city ward. Lots and lots of issues. And they do not have any relationship with GPs. Every single time they see a different GP. There's no continuity of relationship with GPs. So how can you possibly expect our communities to have that relationship, to have this personal, conversation? They only give 8 minutes and only one condition can be discussed at a time. If it is 2, you have to make a double appointment. And that is very rare for them to get. There's so many barriers, constraints to access primary care services. But then accessing sort of secondary, tertiary is almost non-existent. Now, I've touched quite a few. I need to carry on. I'm sorry. So the challenges identified, we talk about in the definition, you cannot have a one fix for all. It doesn't work like that. Each mother's problems are specific, unique, and it's because of their ethnic background, the family background, the social background, cultural background, their faith, everything makes them unique in terms of their specific needs. So if you have a standard, nice based guidelines, that this is nice guidelines, this is what it doesn't work. And even nice guidance, it's all very well on paper, but when it comes to delivery, implementation, it doesn't work because they do not have the resources. To deliver nice guidance, you need huge resources. NHS is resource poor. They work on a budget deficit. They cannot possibly meet any of the needs of even half a dozen people in our community whose needs are growing. And as a result, those health inequalities are increasing because they cannot access any decent, culturally appropriate, accessible, adequate services. So this is why we feel to reduce the burden on NHS, the simplest thing we can do, which would have high impact on our community's health and well-being and reduce the health inequalities, is health literacy. Doesn't require a lot of money, lot of resources, especially if they collaborate with existing, well-established, credible, trusted, local community-based, community-led organizations. We are low-cost, high impact. We are known in Westminster Council throughout the borough as being low-cost, high impact. We enjoy a very high profile. All our staff members, team members, are ordinary local mothers. Tina and Kat mentioned. Even Habiba, people like Habiba, who head of our programs, learning, she was an ordinary mother, joined us as a volunteer with very little or no education. Today, she is so authoritative, competent. She helped me do this presentation, prepare the presentation. I just sent her the content from India. She did this. This shows how much knowledge, skills are available when you empower them. This is why we use an asset-based model. We feel by strengthening the assets within the community, so many assets like Habibas, Janatus, Famidas, so many people, ordinary mothers, by empowering them, enabling them, they can become strong advocates and deliver such high-level knowledge, education, information, and services. They do health checks, they facilitate workshops. Each time Tina or Kat, they facilitate workshops, we follow up for another 2-3 sessions, the same thing we do, same presentations, and we follow up. And our advocates do this, they facilitate this through focus group discussions. So very effective. I've got some disclaimer to sign in. Okay, it's gone. Thank you, Liz. So, just want to. So, how do we integrate this health literacy into your own frameworks? How do we do that? Again, it's become so fashionable to use words like co-production, co-design, and all sorts of co. And even when you're submitting a research grant application to NIHR, you need to have PPI kind of engagement. And co-production is another scoring, I gather. So it's become a tick box. When I ask the researchers, what do you mean by co-production? They They just use synonymously all this co-production, co-design, and they really cannot give you. And the best they can do is recruit some kind of random representatives from global majority communities. And as long as there are Black and ethnic minorities consulted on their panel and on their PPI, that's ticking box. That's enough. And these people may not necessarily be the people who most need these services, most need the research, most need your support and literacy. So co-created communications can be so effective if they're meaningfully created, involving the actual users, actual community who are so deprived, who are so excluded. They're the people who most need to be, included in all your research. And I often hear people saying, "Oh, it's so difficult to recruit people from these communities. They don't want to. They just don't have the time. They don't want to. They just simply say no." But Kat knows, Tina knows why they don't. They say, "No one has contacted us. No one has spoken to us about what this research is about. No one has made us feel important and valuable to be part of that research. We're just token people. They want to be, they just say, oh, we'll give you £20 M&S voucher. Can you please come for a focus group discussion?" And they all come because £20 is a lot of money. But they are not really the right people to be part of your research. So how do we do this? And there are, like Faye again said, text messages, digitally, sort of accessible. None of them have that. They are not digitally savvy. They just do not even have access to broadband or Wi-Fi kind of devices. How do you contact them? They can't speak English. They can't read English. And so this, again, it's so kind of standard practice. Oh, we'll supply interpreters, we'll provide translated information. That's just so ineffective because the interpreters, they don't trust. They are just strangers. Why should they tell the interpreters their problems? And most of the interpreters don't even interpret correctly this information. So they are just not appropriate. They're not trusted. A kind of extension, they're seen as an extension of NHS. So secondly, translated materials. Majority of our people, they can't even read their own language. But they're kind of ashamed to admit. They will tell us, but they don't want us to tell anybody else. Because there's that shame to feel that they can't read and write their own language. And there are languages which are not written, the dialects. So that's another major problem. So they don't read. All this expensive information translated into so many different languages are just binned. And we've been talking to providers about it, but it's all political correctness tick box that they translate, have interpreters, and so on and so forth. And this is just becoming so frustrating to us because we know the problems, we know the solutions, but we feel they're not listening because of political agendas. So, by doing all this, what I just want to say, improve engagement with preconception care, better understanding of personal, yes, this kind of literacy workshops, some of these outcomes, they are now ready for engagement with preconception care if they are available. Better understanding of personalized risk. They know the risk now through these workshops and how these risks can be prevented. And then, of course, this reduced inequalities in maternal and child health. Why we prioritized because of all the reasons I've already mentioned. Because by talking about health through health literacy about maternal genetics, I'll give you an example. Until we had a workshop delivered by Professor Claire Chauvelin on maternal genomics. That's the first ever. They never heard of genetics, never heard of chromosomes, and all of them believed that sex of the child, baby, is determined by the woman. And whenever they had a girl baby, they were blamed for producing another girl child. And this is so common, girl child. In some countries like India, they used to use amniocentesis to do sex detection and have abortions, terminate the pregnancy because unwanted girl child. In those countries, having a boy child is a gift from God. And if you produce a girl, it's a curse from God. So there are these kind of, misconceptions and terrible gender bias in some countries. And therefore, when a woman delivers a girl baby, she is really penalized. She is often seen as, cursed woman. But when we had this genomic session, and for the first time they realized it's the man who decides, the man is responsible for the sex of the child. They just wouldn't believe it. They started celebrating. It was enlightening. So we didn't have anything. It's not our problem. It's not we who are responsible for this. And the way Claire kind of explained to them with these small blocks and colors and shapes and so on to show them the X and XX and XY, and they just loved it. And for days they were communicating this new knowledge, enlightened knowledge with all their family members, not only in the UK, but elsewhere where they come from. They couldn't stop talking about it. It was something like a secret now opened, and they are almost felt relieved. Huge burdens, baggage they were carrying for producing. There were occasions when husbands went and married again when the mother was not producing a boy child. Like I believe Henry VII did, or somebody in those days. So it's not uncommon to do that. So there are so many things. And again, with Kat's workshops, so many myths were kind of dismissed. Lots and lots of myths. Inherited diseases. Again, everything was blamed on the woman. When the child was born with autism or any inherited conditions, it's always woman's fault. So when they had these amazing workshops about how genetics play a role and how couples are engaged and how these close relations, marriages affect this, over 60% of the population are married very, very close cousins. Not just once, twice, for generations. You can imagine the consequences. It's a large, student population in our schools, in our area, with autism, special needs, additional needs, and, physical disabilities. And they didn't relate any of that to these marriages, close marriages. No one has spoken to them. No one has ever mentioned to them. But now through this health literacy workshop, there's so much of awareness. They're teaching their young children about it, the dangers. They're sharing, what they did was wrong, and they should really not do this again. And there's a lot of effective, wonderful dissemination of information, knowledge going on in the community. just with these workshops and how, this preterm births and excessive vomiting. There were workshops which were so relevant in meeting the urgent needs of the community. And it's all this education, information has made a huge impact on the community. They're so excited they access such wonderful knowledge, helpful information, not just through any random source, delivered by highly respected, highly competent, credible people from Imperial. And for everyone respects Imperial College. Anyone like professors from Imperial, consultants from Imperial, are highly respected. But someone from Diabetes UK, Age UK, and Cancer UK coming, the health educators. I'm sorry if one of you are from such organizations, but this is the fact. When they come providing health literacy education, they are unable to clarify any medical clinical issues that are raised by the community. They just do not have that background. So immediately they switch off. These people are just ordinary, mothers like us who receive 3-day training from Royal Society of Public Health, and they come here with a standard presentation, unable to answer any of our questions. So they've told us we're not going to come to these workshops if you bring them. But since then, we've only brought practitioners, people with sound, knowledge, clinical, medical knowledge, and who are respected, who can be respected, and who are prepared to come to our level. All of them. Kath is a professor, she's sitting here, Tina and Susan Barry. The workshop Tina and Susan Barry did on midwifery services, maternity services that are available in St. Mary's was so exciting. People were so excited that all these services are available, but they never accessed. They were so sad that all this is happening, and they were so pleased to meet top people at the community level. And they were sad that when they produced children, none of these facilities, services were available. Nobody really properly communicated with them. No one gave them enough information to be able to make informed decisions or choices, and never made them feel comfortable. In fact, a niece of mine is doing a postdoctoral research on these three C's in University of British Columbia. It's fascinating. Just 3 C's during midwifery. Communication, choice, and comfort, giving them the 3 C's, can make a huge difference to a pregnant mother and during pregnancy and childbirth. And there's so many research studies based on this, and we're not following. It's all on paper, but not being practiced. So all these workshops have, this is the first workshop we did on genomics. Please, if anyone is interested in getting the full report, be happy. And all the successes huge success is based on the relationship we had with the people we collaborated with. For the pre-planning that we do with Kat and her team before a workshop is delivered. And difficult conversations sometimes, but they are so kind of prepared to accept our suggestions. We are nobody compared with the highly qualified, educated, trained, experienced professors and the research team. But still they're prepared to accept our views, our thoughts, our suggestions, and they change their presentations. and prepared to facilitate with us. Because if Kath were to do it on her own, they're not going to listen to her. But we have to be there, provide her with hand-holding support, believe it or not. Otherwise, if you're there and translating Kath's English into their English, they're very happy. And they feel that, Kath suddenly becomes highly credible in their sight because she's co-facilitating. We are delivering it with Kath. Now, Kath, Tina, they become part of Mosaic. They don't see that they are different. They're very much integrated. And the collaboration is working so well. And whatever we deliver, it's delivered through total participation of the community. Oh, I got just 5 minutes. You're the timekeeper. I was wondering why you were looking at me. Okay, so let's go. There's a lot of evidence if you want to know, of the effectiveness of this literacy. This is fantastic. This is a poster, I think abstract poster submitted by Ghosh at the Ghosh conference last year. Did it win anything?
No.
Okay. So it's such a amazing poster which involves all our 6 workshops. And is it here? That's good. Then I skipped that. It's amazing. So 5 minutes. I just cannot, stress strongly enough the importance of health literacy and the importance of collaborating with a community-based, established, credible, trusted, community-based community organization. If you can collaborate with such organizations and deliver your health literacy, it would have enormous impact on the community, in terms of preventing unnecessary issues, inherited issues, problems, complications during pregnancy and childbirth, and that, for the entire well-being, the maternal health. And this is so empowering. It's a transformational intervention, just health literacy. And it's easy, cost-effective, and result-focused. So I just want to end my talk with that encouraging words. Please talk about health literacy whenever you can, and without giving your patients, your mothers and couples knowledge, information, and your time, you cannot expect them to change and have positive health outcomes. Thank you.
I think we're running slightly behind, so I think we're going to do questions later. But first of all, I would like to introduce our next speaker, Professor Catherine Williamson, who is a Professor of Women's Health at Imperial College London and Director of Tommy's National Research Centre for Preterm Birth Research in the UK. We are also grateful to Kath because she managed to break away from speaking at a conference in Leeds to be with us this afternoon, and we are most grateful for your time. Kath is an expert in maternal medicine, researching gestational diabetes, severe hyperemesis, and intrahepatic cholestasis. She focuses on improving clinical outcomes and preconception planning. So please give a warm welcome to Professor Kath Williamson.
I hope it works. And if you don't hear me, let me know. It's an absolute privilege to follow Lena, with whom we've had such an amazing working relationship and two-way education. And I think a lot of what Lena has said is going to resonate in what I'm going to talk to you about. An absolute privilege to be invited by Tina as well, with whom we've done so much of this work. So I'm happy to be here. I'm an obstetric physician, so I trained in medical disorders of pregnancy. I'm also a clinical researcher. I'm going to start with epidemiology, consider disparities in preconception care, how we can try to address that. I will come to some genomics, but then back really to, I think, echo some of the messages that Lena has given us about the importance of working with the people we're looking after in our communities if we're going to be effective at delivering good preconception care. So I'm going to start thinking about maternal mortality, which is the tip of an iceberg of the worst outcomes we want to avoid. I had the privilege of being an assessor on the maternal mortality reports for about 10 years. I stopped about 8 years ago. Every report, we thought we were doing well in the UK. These are UK data. Maternal mortality looked like it was coming down. Then, around about 2018, it started to tick up again. Now, many of you might be thinking, oh, that's COVID. COVID happened after that. And that was part of it. But if you can see the blue line in the upswing, that's adjusting for COVID deaths. So despite that, maternal mortality is no longer getting better in this country. It's getting worse. And we have to really think about why that might be. So in terms of why women die, this is a busy slide. Essentially, the hashed bars are causes of death which relate to pregnancy directly. So some of the titles here are preeclampsia, amniotic fluid embolism. They only occur in pregnancy. The solid lines are pre-existing conditions or non-pregnancy related conditions. COVID is the big one on the left. Then heart diseases. In the middle one, with both shading, is mental health causes of death. Some related directly to pregnancy, some not. And you go to neurology there. You heard about epilepsy earlier. It's really important. It's a major cause of women dying still in pregnancy and can be, there's definite evidence that it can be improved with good pre-pregnancy advice and counselling. So a large number of conditions there. Another way that confidential mortality has looked at why women die is looking at groups of etiological factors, underlying factors. So on the left bar there is obesity. But you go for along the big, tallest peak is pre-existing medical diseases. And more than 50% of women who die in this country in pregnancy have a pre-existing condition. So those are women that really should be getting advice to optimise their health. And hopefully, I would agree with Lena, have health literacy so they know how to optimise their health. They can advocate for themselves, but they need advice, they need information. And pre-pregnancy care can give them that. What we are aiming to deliver and to deliver more and more is pre-pregnancy counselling. So people are empowered and informed about how to optimise their own health. An important other piece of information from the confidential inquiries, we always look to score whether a particular case had substandard care. And we also look at whether different management might have changed the outcome. And consistently, every year I assessed, about a third of cases had substandard care, where different care and better care could have changed the outcome. Every report advised that there should be more multidisciplinary working, more communication, and pre-pregnancy counselling. So very, very important messages. Another message that comes from the confidential inquiry is about disparities. And one important message relates to ethnicity. Many of you will have heard these messages. We all know them now, but the crosses at the top, that represents Black women who are three times more likely to die in pregnancy. The next label down, although it's not quite so obvious, the triangles, the black triangles are Asian, really South Asian women. The solid circles at the bottom are white women. No woman should have an unavoidable death in pregnancy, but it's very concerning that South Asian and Black women have higher rates. And again, we need to think about ways to address this and avoid this, and this should suffuse everything we're doing for preconception care. There are a number of charities now. There are amazing organisations like Mosaic Community Trust who are addressing this. I can't put all the names here, but it's really important that women are starting to advocate for themselves. They want this to be addressed. We all have to work as a team. The confidential inquiries did look at a number of the issues that cause people to be more likely to die. So here we have minority groups. Over on the right, physical health problems, pre-existing disease. But many of these dots relate to economic disadvantage. This is a massive thing that I believe people in the UK don't really talk about class or economic deprivation as much as we probably should. People living in deprived areas, known to social services, smoking, unemployment. These are all, so it's a complex, so-called wicked problem. And we have to think about dissecting out what we can address together. They talked about a constellation of biases, and most women had multiple problems, not just one issue that makes them more at risk. So it's complex, and we have to think in a nuanced way about this, individualising, but also thinking broadly. So a message from Membrace related to those with pre-existing disorders. High-level actions are needed to ensure that physicians are appropriately trained in and engaged with the care of pregnant women, and that services are designed for women with medical conditions to provide appropriate and evidence-based care across the entire pathway. Now, of course, that's pre-pregnancy, during pregnancy, and of course after pregnancy, although we're thinking really now about preconception care. And women with pre-existing medical conditions should have pre-pregnancy counselling by doctors with experience of managing their disease in pregnancy. As Lena says, many people can be credible, but you need to make sure you're knowledgeable and credible if you're going to be doing this. And the messages have to get out. People have to be educated so they know the right information to give people to empower them to be looked after well and advocate for their own care. So this is just an infographic from the confidential inquiries. Before pregnancy, it mentions contraception as well as pre-pregnancy advice. There's good evidence shorter inter-pregnancy interval is associated with poorer outcomes. We have to empower young women. We have to empower very young women to know about contraception so they have control over their reproductive choices. That is part of what we have to think about in pre-pregnancy care. Optimising medicine for the people I look after, not advising people and telling them, do we need to stop the medicine? Don't we change the medicines? Make sure they know what needs to be done. So many women stop their medication because they think they're doing the right thing for their baby, or somebody's told them they are. It actually makes them very sick and sometimes die. They need the right information. Special considerations related to their condition, and also thinking about management after pregnancy. If this is all covered pre-conception, they have a plan, they're empowered. We know what to do. And ideally, the plan can be publicised so everyone knows what to do. I really like this image. It comes from the confidential inquiry and really, again, shows how complex the issue is. But the message going round, the whole jigsaw, is treat women who may become pregnant, are pregnant, or have recently been pregnant the same as a non-pregnant person, unless there's a very clear reason not to. And I think this is a massive issue that pervades society. Pregnant and lactating women often don't have the privilege of good research, good care, because they're excluded. We have to treat them the same unless there's a good reason not to. Another piece of this jigsaw I really like is pre-pregnancy advice, including contraception. So again, just underlining how important this is. So why do many women with pre-existing diseases die? This is a US set of data, but it's important. Most people have the common conditions: hypertension, diabetes, obesity is common. They have their advanced maternal age, many pregnancies. But I would estimate, I'll come back to this towards the end, 10 to 15% of women of reproductive age in our populations, and particularly in the populations that we're working with Lena, have hypertension and diabetes and may not know it. We have to empower people. We have to work so we can identify these people, because then we're going to improve their outcomes. And again, that's part of our preconception care. So I've been talking about mortality, death, but that's just the tip of a massive iceberg. Under that, thankfully, are all the people who don't die, but have the chronic conditions. Some of the common ones you've heard about: epilepsy, metabolic disorders, which is a whole combination, in a sense, of pre-pregnancy diabetes. Many conditions that are associated with obesity, such as fatty liver, is becoming commoner and commoner. Hypertension, hypertensive disorders, underlying heart disease. And again, many people have more than one, multimorbidity. So these are pre-existing disorders, but there are also the gestational disorders. And a lot of people present in pregnancy, and pregnancy is almost a stress test for life, where we identify people at risk of conditions. Their diabetes might present for the first time in pregnancy, their hypertension. We get them then, we can keep them healthy long term, but we have to have strategies, we have to have an infrastructure that lets us do that, which we don't have at the moment. So this slide just summarises some of the common pregnancy disorders, many of which we don't know about until a woman's pregnant. Gestational diabetes, 10 to 15%, and ethnic differences in prevalence. Preeclampsia, about 2 to 3%. Hyperemesis, about 2%. Cholestasis, about 1%. And all of these conditions associated with higher rates of preterm birth. 8% of pregnancies in this country are born preterm. We're aiming to reduce the proportion to 6%, but we haven't succeeded yet. Stillbirth, 1 in 250 pregnancies. And again, Black and South Asian women have these complications more. There are cases that are preventable. So pre-pregnancy advice will potentially, if we can harness it, be a very effective way. So to come on to think about, for what I do, pre-pregnancy counselling for maternal diseases. The aim is to recognise and amend risks for the woman's health or pregnancy outcome, reducing, of course, death, morbidity, or if they're not modifiable. Some women, you can't modify the risk, but you can talk to them, you can educate them, you can empower them and make joint decisions about the best thing to do. Far better to do that before they become pregnant, or certainly in early pregnancy, so we can jointly come to decisions about what to do. So the way I think about pre-pregnancy counselling and what I say to people when they come is the first thing we do is think about the effect of the disease on their pregnancy. Then we talk about the effect of their pregnancy on their disease. The medicines they're taking, safety, and the safety of some medicines may be different in the first trimester to the third trimester. So a nuanced discussion, individualised about that person, and always emphasising the importance of the multidisciplinary team, because good care is definitely delivered better with multidisciplinary teams. I had the privilege of coordinating the European guidance and the international guidance on liver disease in pregnancy. And 2 of our research priorities were pre-pregnancy counselling and multidisciplinary team working. We then went to look for the research. There is very little on pre-pregnancy counselling. I'll tell you a bit about what there is. There's almost nothing on multidisciplinary team working, certainly within our fields, which is astounding when anecdotally we can all feel and see how important it is. So please, people, we need more research on that. But in terms of pre-pregnancy counselling, I'm sure you've heard this a lot through the day. The important thing is sharing information, speaking to people in a way they can understand what you're saying, and talking about weighing risks and benefits at different stages and the different aspects of either the risk of the condition, the risk of the intervention, be it a medication, decisions around delivery, and coming to joint decisions and enabling the person you'll talk to participate in the choices that are being made. And Lena said it much better than me. Language is important, communicating is important, and making sure people understand what you say. But just as a simple example from our practice, some people take medications that cause such high congenital malformation rates, we really want to change the drug before somebody gets pregnant. And the type of thing somebody might say is, you cannot get pregnant by taking this information. I have had women turn up pregnant because they thought that meant they're not going to get pregnant because they're taking that medication. They're not going to be fertile. So the words matter. You must not get pregnant when taking this medication. I'm sure I'm preaching to the converted here, but I work for some of the conditions that I manage with the transition clinics and my lovely, lovely paediatric colleagues who look after children with, many of them with genetic diseases or chronic diseases that develop in childhood. They're wonderful. They're caring. They have really good relationships. They very rarely talk about sex, contraception, or pregnancy. And some of the women leave the transition clinic at the age of 25 or 26, but they come to us when they're pregnant. So we have to do it as a community, multidisciplinary working, and make sure all of our colleagues know this. And another thing we have to talk about, as you know, I'm very involved with preterm birth, but preterm birth is important. As I said, 8% in this country, we should have lower rates. And women with pre-existing diseases have higher rates of preterm birth. And if we optimise their care, it's likely to reduce. So pre-pregnancy counselling is about the woman's health. It's also about the pregnancy outcome and the subsequent health of the child. And I have some examples here of conditions where this is very clear. It's really important. If we can optimise health and move somebody from a preterm birth at 24 weeks to 28 or 28 to 32, then we're going to reduce respiratory distress. This graph is too small for you to read, but this is 34 weeks. That's 36 weeks, that's 37. Respiratory distress and admission to neonatal units as a consequence. So advising and shifting that, really important. Many of you will have seen this type of graph. This is the proportion of children with special educational needs going from being born at 24 weeks through to 43. So again, just shifting a few weeks could make a massive difference. It's really important to try to optimise health and involve people in that to improve the outcomes for their children as well. So does pre-pregnancy counselling work for medical conditions? Well, as I said, there's not much evidence. The best evidence is in diabetes. I'm just showing you here some results of a meta-analysis of 21 studies. And the essence of the message is pre-pregnancy counselling did reduce the rate of congenital malformations. That's because good glucose control in the first trimester reduces the rate of congenital malformations. Reduced perinatal mortality, so less stillbirth, less early neonatal deaths, again with better control and avoiding preterm births. Actually, for preterm delivery, the jury was out a bit, and I think it has to be nuanced a bit more. But it showed that pre-pregnancy counselling worked. There's almost nothing else. As I said, when we wrote this guideline, we looked at what there was for medical conditions. We did a whole search of the literature. We identified about 11,000 potential papers on a search. But they went down when we screened them to 10,000, and more than 10,000 were excluded. We had 47 that were actually eligible to look at real pre-pregnancy counselling and what effect. And a lot of them were lost because they were refused or didn't report outcomes. We had 6 papers in the end, having gone through all the literature. But from them, there were 2 on inflammatory bowel disease, Crohn's, ulcerative colitis, 2 on epilepsy, 1 on cardiovascular disease, and 1 on autoimmune rheumatic disease, like lupus and conditions like that. One important message, those that attended for pre-pregnancy counselling, they tended to be younger, but they tended to have higher educational attainment, more frequent employment, and more often attending for IVF, so fertility. So these are empowered, educated people. Now, I'm delighted they're getting pre-pregnancy counselling, but to go back to what Lena was talking about, we need everybody to have the opportunity to have pre-pregnancy counselling. So we have to think about how we can address that, and I'm going to come back to that at the end of the talk. But what did we find? Again, it's a very busy slide, and what we really found is summarised on the right. But going through the columns in this study, the third one along is behaviours. So women not stopping their medicine if they shouldn't stop the medicine, taking folic acid, smoking cessation, and certainly for inflammatory bowel disease and epilepsy, where they had those outcomes, pre-pregnancy counselling improved them. The next column is activity of the disease, having more severe disease. Again, if you optimise medication, you optimise disease. And for almost all of them, there was improved severity of or less severe disease. And in terms of pregnancy outcome, less preterm birth, less pregnancy loss, both miscarriage and perinatal mortality, fewer congenital malformations. So it's tiny numbers, but the emerging evidence suggests it works. So just to finish with a vignette related to this from the confidential mortality and why it's so important. This is on epilepsy. A woman with learning difficulties had increased seizure frequency in the first trimester. She had discontinued her lamotrigine. I imagine Dominic Neely told you earlier, lamotrigine has enhanced excretion in the first trimester. If women know that, if clinicians know that, if it's in a letter, you make sure they increase their dose, and they know that's a good thing to do. She was referred. She stopped the drug because she was concerned it might damage her baby. Referred to the emergency department by her midwife because she said she was having more seizures. There was no change in management. She was referred to her GP, but her GP is not a specialist. And no advice. She was risk assessed, deemed to be at high risk, was referred, she died from sudden unexplained death. Likely because of having more seizures before she saw an epilepsy specialist or an obstetrician. If we have proper pre-pregnancy counselling and pre-pregnancy care, we should be working with women to avoid this. So I thought that everything I've said feels so important because a lot of the issues around pre-pregnancy care are not so related to genomics as disparities, and it's the most important thing we have to work together to address. But I know that people here will want to know about genomics, and I'm delighted to see Colette Sprace here as well from NHS England, who's doing amazing works related particularly to monogenic diabetes. So for all of the common disorders, and of course for the more monogenic genetic disorders, there are increasing interventions we can use in pregnancy. Gestational diabetes, I believe, is the low-hanging fruit where we can really make a difference soon. It's common, as I said earlier, 10 to 15% of pregnancies on a global scale, particularly in the global majority, commoner, and in South Asian women in particular, considerably commoner than in white women. But it's common for everyone. It has short-term and long-term adverse outcomes, and I think I don't need to talk in detail about these. You all know them. About 1 to 3% of women that present with gestational diabetes or that have people with diabetes outside pregnancy have monogenic diabetes. It's a complex disorder with lots of underlying etiologies, and a small proportion have monogenic diabetes. There are 4 main genes that cause this. Glucokinase, HNF1 alpha, HNF4 alpha, HNF1 beta. The names don't really matter, but there are 4 main genes. And they're important in pregnancy because if the fetus inherits them, it makes a difference to some of the outcomes. So there's a really good argument that we should start thinking about this in our pregnant population. I'm going to tell you a little bit about some of them. Glucokinase, which is the one that Colette's done amazing work on, and we're going to have a guideline very soon telling people what to do, which is amazing. This is the commonest of the monogenic diabetes, and it's really a set point mutation. So people with mutations in glucokinase run through their lives with slightly higher glucose in their blood. So if they're picked up in pregnancy, particularly if they have that fasting glucose a bit high, people diagnose them as having gestational diabetes. But because it's a set point abnormality, I've seen women who've been given insulin to try to drive their glucose down. They have a different set point, so they get the awful feelings of being hypoglycemic as we try to drive them down when they don't necessarily need it. And they have normal life expectancy outside of pregnancy, so they don't need treatment. So if we can pick these people up, we can let them avoid this. However, there is a however for pregnancy. Inheritance of the mother's mutation can affect the growth of the baby. And this is particularly, in this case, if the baby does not inherit the mother's mutation. So if you just look at the graph on the right, essentially you can't really read the fuzzy writing at the bottom, but it's whether the mother has a mutation and whether the baby inherits it. If the mother has a mutation to cause her to have glucokinase diabetes, so glucose is a bit high. As most of you will know, glucose crosses the placenta. The baby sees more glucose, it will release insulin and grow a bit more. So if the baby's normal and doesn't have the mother's mutation, it's about 600 grams larger, which is why that's the birth weight centile on the x-axis in this graph. The first column is those where the mum has the mutation and the baby does not. But if the baby inherits the mutation, it also has the set point. So the more glucose going from the mother, the set point will essentially cause normal insulin secretion and it will grow normally. So it's on the 50th percentile. That's the second column along, which is exactly the same as normal pregnancy with no mutations in mum or baby, which is the third column. The fourth column is where the mother doesn't have a mutation, but the baby will have inherited it from the father. Then it has the different set point. The mother will have less glucose going across, so it grows less. So it can cause the babies to be small. And it's a beautiful, elegant model that actually seems to pan out in real life in this subgroup of pregnancies. So it's worth us knowing, particularly because worries about obstruction in birth and birth trauma, we want to predict in mothers with this mutation whether the baby has not inherited the mutation. Because if it has, there's nothing to be done. And we don't have to force her to try to drive her glucose down for no reason. But we do want to screen if the baby has not inherited. If we think about the others, this one is HNF1 alpha. As I said, the name doesn't really matter, but this type of monogenic diabetes, it presents in a very similar way to other diabetes outside pregnancy, high 2L glucose and glucose tolerance tests. But the different thing about them, they're very sensitive to sulfonylurea drugs. So they, on about a quarter of the normal dose, respond really well and have good glycemic control. So if they're picked up, rather than driving them with other medicines, they can be on the right medicine. Now, the only challenge in pregnancy is sulfonylurea across the placenta. And in the third trimester, there's reluctance to give them because they can cause the baby to get hypo. But you can optimize management if you pick it up. And the important thing is picking it up and treating people right. And they have good treatment after pregnancy. One of the other HNFs, the HNF4 alpha, this is similar to the other one, but the babies inheriting this mutation are really big. When Andrew Hattersley, who's the national expert on monogenic diabetes, talks about this, he shows headlines from papers. There's one of the biggest ever baby in Bradford. And these are people where if the baby inherits the mutation, it can be very, very macrosomic and big. And that's a concern and you want to pick up on it. They're also very sensitive to sulfonylureas, so they can be managed in a similar way to the other one outside of pregnancy and in pregnancy. But you want to pick them up and really focus on glycemic control to try to avoid this marked macrosomia. And then think about delivery. So there are two types. I won't go on about other monogenic diabetes, but it's really worth us knowing about this, and we can do it now. So this is moving to high tech, but there are tests, and this is just one paper. And I think this was from the Hattersley group again, but it certainly showed that there are tests where you can identify fetal DNA in maternal blood and establish whether there's inheritance or non-inheritance of the mutation to allow you to then properly plan pregnancy. So this is a group within genomic care as well, where if we bring women, if possible, for pre-pregnancy counselling or pick them up in pregnancy, give them rapid genetic testing, because it's only in the second half of pregnancy we start intervening and thinking about growth. We can give them much better management. So Colette's guideline is going to be wonderful soon for glucokinase. Then the team is going to move on to do the others. And we're also going to have a Royal College Green Top guideline. Almost certainly it's going through hopefully the final ratification now. So give us a couple of years. I have the privilege of being on the RCOG Genomics Committee, and this is going to be our first maternal medicine deliverable, I think, which feels important. Anyone interested, be in touch, but soon we'll be able to tell you more about that. So just going back to the study we did, and where I mentioned that those who are having pre-pregnancy counselling at the moment tend to be more empowered, more educated. I want everyone to have pre-pregnancy counselling. I'm delighted they're coming, but I want us to provide it for everyone. So we need to move forward. We need to talk about ways to deliver pre-pregnancy counselling to everyone who needs it, and particularly people with hidden morbidity in the community before they get pregnant. Lena has mentioned our workshops. I couldn't raise this without talking about the amazing work that Lena, Habiba, Mosaic Community Trust doing. I think health literacy is definitely what we need to work on. We need to find ways to tell the entire community and to communicate and hopefully be trusted by the entire community to tell them about risks and empower them to have the care that they need. Our final workshop, which Lena didn't actually talk about, we had two, and Tina was so instrumental in this as well. And even before we did the workshops, you had done the workshop with Claire Shovelin and brought the wisdom from that. We wanted to do workshops on preterm birth and genomics because we were part-funded by Genomics England as well as Thomas. But we also wanted to know what workshops the women wanted. So they decided the other topics. And actually, I'm delighted. We've somehow managed to squeeze enough money out. We're going to do one on mental health soon as well. But we decided the final workshop should be really bringing together thoughts about what we've learned and thinking of what we can do next. We didn't want to, when the funding ended, to just leave them. And we had a really constructive discussion with politicians, people from the primary care community, from the university, really talking about how we can hopefully take this forward and ways to empower the community and improve health literacy. And one of our wonderful people who worked on it, both Megumi Nomura and Olivia Walker, did a real hard graft from our side to set this up. And Olivia is going to be writing up workshops, and I'm hoping we're going to manage to have developing a toolkit so we can use the wisdom gleaned to help other groups, as Lena said, other communities. It might be different for the Chinese community, for the Jewish community in different parts, for Black communities in different parts of London, but try to work with people to find the best way to deliver workshops for them. So it was an absolute privilege, and I think we all learned a phenomenal amount while we were doing the work. I don't really need to show you the feedback because you've seen it and you can see it there, so I'll slide past this. A couple of other small initiatives we have. Tommy's have just funded 2 studies. One for medical disease, strategies to access the women with the hypertension, the diabetes, the renal disease in the community. And one idea we had was not everyone is empowered to come to pre-pregnancy counselling, even though we have a network to deliver it. But we thought everyone goes to hospital when they have a miscarriage. And miscarriage, these are all risk factors for miscarriage. So we're developing a point of care test for people with miscarriage and to get them to medical clinics within 6 weeks, which our maternal medicine network has funded to provide, as many of you will know. This was a wonderful NHS England initiative that is now funded. If it works, I welcome everyone's ideas on how we can generalise it more. And the Liverpool team, again through Tommy's, are developing a great initiative with their population for people after they've had a spontaneous preterm birth. They're running focus groups. They want to co-design the best way to deliver their clinics, their pre-pregnancy counselling. So we'll be coming at it from two angles. I know other people are being funded for this. I know NIHR wants to fund it more. So hopefully between us, we can really start to develop better ways to provide pre-pregnancy counselling. I just wanted to show there are some papers, but I was shocked at how few. Let's hope I can't fit them all on a slide in a few years' time. So most guidelines recommend pre-pregnancy counselling, but there's almost no research. We need to generate the research. The studies in diabetes show it does have an impact. The limited data for other disorders do. Let's find solutions for the inequalities in access, because that's our major issue. We don't want to be providing, or we do want to be providing wonderful pre-pregnancy counselling for empowered people, but we want to provide it for everyone, and we want to make sure it's a fair resource. There are so many thank yous, I don't know where to go, for the work that we've done and what I'm telling you about. There's a photograph there of our Women's Health Research Centre at Imperial. Many of the wonderful people who work there are here, including Tina, where that's another one of her hats. India and Chiara at the back do a lot of work recruiting people to trials. I've got the names of the people who run the workshops and the people who are delivering some of the pre-pregnancy counselling research now. There are so many collaborators, so not everyone can be mentioned. Thank you.
Pleasure to be the genomic thing and lead now. I'm also now lead my client for genomics in England. So I'm responsible for all of you to make sure that you're all able to use genomics in your practice. So don't start throwing tomatoes at me, guys. But on a serious point, I'd really like to thank Liz, Tina, Dominic, the whole of the GMS team. They have done a brilliant job. So a round of applause, I think, to them. That we have learned so much today, and the strapline that I'm going to go away with is: in pregnancy, it's too little, too late. We've missed the boat. By that stage, we really need to be thinking about where we need to go. That one size does not fit all. We know that in every other part of health, so it's absolutely the same within preconception care. But we also recognise it's complex. There are so many moving parts, so many different conditions, so many different. Actually, it's going to be a real challenge to move this forward. But we are an amazing group of professionals. So collectively, we have the power to make a difference. There is no one professional group who is responsible. And I think that then lingers into there's no commissioning of preconceptual care services. So therefore, when you get somebody like all of our speakers here who've been amazing individual clinicians, they're the ones driving the service. We should not have that. It should not be a postcode lottery, and it should be that it is a standard commission service across the country. That's where I come in, because that's part of my role in NHS England. I'm not going to crack it on my own, so I do need all of your support. We've got the opportunity of feeding this into the Women's Health Strategy. I know that West Beating is currently reviewing that and it's being updated. So now's our opportunity, guys. Get your pens out, get your computers out. Please email him and Secretary of State for health, for women's health, whoever you can, get your pens going. We have the huge potential to both maximise maternal, fetal, neonatal and child health across the generations. We also have the real potential to save money. Now, I know we shouldn't be talking about money, but health does cost money, and we have to acknowledge that. We need each other. We need education. Our undergraduates and our postgraduate students in all areas need to know what this is about. I was talking to a number of you earlier on, and none of us do preconceptual care within our training, even some who are more recently qualified. So there's definitely a gap there. The issues around the 10-year plan, it's very ambitious, it gives us lots of opportunity. But this issue around having the neighbourhood services is a golden opportunity, both for us as individuals and healthcare professionals. We know that cardiac, neurology, and mental health are the three main areas that we need to consider, but they're not exclusive. Ultimately, all I want to say is we need to move this to a place where it is personalised and that it's normalised so that every single person, both men and women, have the opportunity to get real proper preconceptual care. You are incredible. You have such a strength of will and knowledge behind you. Go for it. And good luck. Thank you very much.